Buenos días a todos los que están hoy día en esta actividad académica. Se está grabando para que la tengamos en el canal oficial del SLARP. Y bueno, empezamos con una gran profesora, la doctora Teresa Chapman, de la Universidad de Wisconsin. Así que yo estoy muy feliz de empezar.
Estamos muy felices de poder empezar este año con la presencia de la doctora Teresa Chapman esta mañana, la cual estamos seguros hará una maravillosa presentación. Buenos días, doctora Teresa.
Buenos días. Muchas gracias. Can you hear me okay?
Sí.
Yes, we can.
Okay. Okay, wonderful. It's very nice to be here today. Thank you all so much for having me. So I'm going to be talking about lesions in the pediatric breast and how to diagnose them and when to biopsy them. So first, to begin, I want to acknowledge one of my colleagues, Dr. Ricardo Restrepo from Miami, Florida. He gave me several wonderful cases that I have included in the presentation today, and so want to thank Ricardo for that. By the end of this presentation, I want all of you to be able to recognize normal glandular tissue in the pediatric patient and apply appropriate management recommendations to breast ultrasound findings of an infant, a child, and an adolescent with a palpable breast abnormality. And then finally, we should all be able to provide an appropriate differential diagnosis for a solid tissue finding in the pediatric breast. So to begin, I want to just emphasize a few things that I want to be sure everybody walks away knowing. So first, the lesion that you're looking at on a pediatric breast ultrasound is almost certainly benign. And a recommendation for fine needle aspiration or a core needle biopsy of a subareolar lesion, a lesion just deep to the nipple, in a young child risks causing harm to the breast bud. So you don't want to do that. And then the second point of emphasis is that when assessing a child or an adolescent with a solid breast mass, first determine if the patient has any known malignancy, any history of cancer. And if so, assume that you are actually looking at a metastatic lesion. And if not, if no history of cancer, then the lesion you're looking at is almost certainly benign. Okay, so it's appropriate to biopsy in the following main categories. And of course, we'll talk about a lot of different cases, but to emphasize, it's appropriate to biopsy a solid mass that is rapidly enlarging. So either by clinical history or by comparison to prior imaging, if there's evidence of rapid enlargement, it's appropriate to biopsy. It's appropriate to biopsy a solid mass that's large, meaning about 5 centimeters in size. And it's appropriate to biopsy any mass in a patient with a known malignancy, even if the features of that solid breast mass look relatively benign. We have to assume that's metastatic disease if they have a history of cancer. And then finally, a solid mass in a patient with a BRCA mutation or prior radiation therapy to the chest wall. That would be much less likely, very uncommon in the child. But these are categories where it is appropriate to biopsy a solid breast mass in a pediatric patient. So As far as the modality for assessing the pediatric breast and a palpable mass, ultrasound is the modality, only ultrasound. So I want to emphasize that there is no role at all for mammography or MRI in evaluation of a solid breast mass in a pediatric patient. So breast MRI should only be used in adults for very well indicated situations. Okay, there's also commonly a question about the BI-RADS ultrasound lexicon. So in the United States, we follow the American College of Recommendation BI-RADS recommendations that categorizes the likelihood of cancer in a visualized breast abnormality. But we do not use this in pediatric imaging. So you do not have to assign a BI-RADS category if that is your practice with your adult patients. But it is useful to use the ACR breast ultrasound lexicon to describe masses. So these are the words that are appropriate to use when describing a mass as far as the shape, oval, round, or irregular. The orientation, is it parallel to the chest wall or not parallel to the chest wall? What are the margins like? Or is it well circumscribed? Is it not circumscribed? Are the margins indistinct, angular, microlobulated, or spiculated? These are the words that are appropriate to use. And then as far as the internal echo pattern, we'll describe these solid masses as anechoic, hyperechoic, complex cystic and solid, hypoechoic, isoechoic, or heterogeneous. And then also comment on the posterior acoustic features. So is there posterior acoustic enhancement or shadowing or both? Okay, and at the end of this talk, I will summarize all of these all of these management possibilities, depending on what we see, the clinical situation. But this is a paper that summarizes these recommendations from several years ago that still applies. Don't feel like you have to read this slide quickly. I'll go through this more slowly later. So as far as the breast ultrasound procedure, first, you want to ensure the patient is covered, warm, and comfortable. Needless to say, this can be an uncomfortable exam for young girls and teenage girls. So we'll use a linear high resolution transducer and we'll just focus on the palpable abnormality only. So there's no role for sonographic screening for ultrasound screening of an asymptomatic breast in a child. That is not standard of care. So you don't need to look at the asymptomatic breast tissue. You just focus on the palpable abnormality. If you do scan the asymptomatic breast tissue, either in the same breast or the contralateral breast, just be aware that you might find additional lesions that are asymptomatic and they're unchanging and irrelevant, but then you're sort of stuck managing those and it's best just not to look, truly. So the other thing that I want to point out is some pitfalls of imaging with breast ultrasound. The ribs can be confusing. So the ribs are obviously bones that will cause posterior acoustic shadowing. And the pediatric chest wall and breast tissue is quite shallow. And so you will see the ribs right away, and it can be confusing. The other confusing thing is a fat lobule. So a fat lobule can mimic an isoechoic mass in cross-section like this. You might think that these are masses, but no, it's just normal fat. And then finally, Cooper's ligaments are these echogenic structures, and note how it's causing posterior acoustic shadowing. So that can be confusing too. And so the way to sort this out is just to simply turn your transducer or change the pressure, and it will become apparent that these are not masses and in fact are normal breast structures. Okay, so the chest wall is defined by the pectoralis muscle here. So the ribs are here, and then the pectoralis muscle. Superficial to the pectoralis muscle is the breast tissue. And of course, this is the skin. So often a very narrow, shallow structure in the underdeveloped breast. Now let's talk about certain ages and particularly the infant, because this is interesting and can be very confusing. Subareolar nodules in infants occur normally. This is normal. And it's because following birth, the disappearance of the placental hormones, specifically the estrogen that had come from the placenta that circulates in the infant for a while, that disappears. And once that disappears, then the hypothalamic pituitary gonadal axis is released from suppression. And so babies get this sort of mini puberty, and the breast tissue responds to that. And so babies can have sort of prominent subareolar nodules, and that's normal. And this is what it looks like on ultrasound. We can see a fairly well circumscribed, heterogeneous, parallel, solid mass, if you will. But this is normal, and it usually regresses by 12 months of age. Then the child will go through the first decade of life or so, and then hit puberty. And thelarchy is the word that refers to breast bud development during puberty. So this is thanks to estrogen and progesterone. Those two hormones both trigger different developmental occurrences in the breast tissue. The normal age of onset of thelarchy is 8 years to 13 years in the girl. Okay, so let's talk about normal breast development then, and ultrasound stages. These more or less match with Tanner stages of development, but this is specifically ultrasound. So in the beginning, in babies, all we have is a little bit of echogenic subareolar tissue. This is pre-thelarchy, and this is normal. This is what an infant's breast tissue looks like. And then once puberty begins, we start at stage 2. So this is the breast bud stage. And you can see here, just deep to the nipple, we have on each side a sort of oval, partially circumscribed, hypoechoic solid nodule. This is normal. This is nothing to worry about. And then with stage 2, as puberty continues, that breast bud enlarges, and you can see the margins sort of look a little spiculated. They extend outward, kind of like in a spidery manifestation. This is stage 3. And then as puberty continues, we go on to stage 4, and that breast bud elongates more, as you can see, and we have increasing adjacent fatty tissue. And then the mature adult stage is stage 5. This is the fully developed breast. And here we have loss of the hypoechoic breast bud. And this is what we're used to seeing on adult breast ultrasound. So hypoechoic fat lobules intermixed with echogenic glandular and stromal tissue. All right, so let's look at some cases and help us figure out what do we do when we see lesions in the pediatric breast. So I just want to emphasize again, malignant findings in the pediatric breast are rare, and tissue sampling will usually not be appropriate. Okay, well, I meant to say will usually tissue sampling will usually not be appropriate. That slide is poorly worded. Sorry about that. I did not notice that. Okay, so let's talk about these. The first case is that of a palpable axillary abnormality. So an 11-year-old girl presents with a palpable abnormality in the right axilla. And a palpable abnormality is an indication for ultrasound evaluation. It tells us that something is changing and may be abnormal. So let's do ultrasound on this 11-year-old. And here's what we see in the right axilla: an ill-defined oblong heterogeneous mass. So this is an example of polymastia, or accessory breast tissue. The term polythelia refers to accessory nipples, but actual accessory breast tissue is polymastia. And this is due to failed regression of these paired strips of epidermal cells in the embryo that extend from the axilla to the groin. And they normally regress, these ridges of tissue, except at the fourth intercostal space where the breast tissue should develop. And so rudimentary mammary buds then will develop into normal ducts and supportive stroma. But if these ridges fail to regress, then we can end up with accessory breast tissue. And that tissue will respond to hormones, just like normal breast tissue. So at puberty or during menarche, during pregnancy or lactation, that accessory breast tissue will enlarge and become symptomatic. And the clue is its location along these lines, and the sonographic appearance is very similar to normal breast tissue. Okay, here's another case. This is a case of an 8-year-old girl who's presenting with unilateral breast pain. And new breast pain is an appropriate indication for ultrasound because, again, it implies something is new or changing. So let's look at this. So here we have the right and the left side both imaged, and this just represents stage 3 breast development. So we see normal breast buds that are elongating with, again, those angular kind of spiculated margins. The left side, the symptomatic side, is larger than the right. And this case just points out that asymmetric breast tissue development is totally normal, nothing to worry about. And so you do not want to recommend biopsy in a case like this. Trauma to the breast bud will affect normal breast tissue development and create a cosmetic problem for that girl later in life. So don't touch this. This is totally normal. All right, this is a new case. This is a baby now with new breast swelling. And a palpable nodule or mass is, again, an appropriate indication for ultrasound. So we're going to use ultrasound here. And we do see a solid mass. So in the breast, there is this partially circumscribed heterogeneous lesion parallel to the chest wall. And with color Doppler, there's some internal vascularity. And so this is an example of an infantile hemangioma. And again, here are the descriptors. It's subareolar, partially circumscribed, heterogeneous echotexture, parallel orientation, and hypervascularity. This is what virtually all infantile hemangiomas look like in the breast. And this is a benign vascular neoplasm that undergoes a rapid growth phase followed by involution. So here is a companion case, different baby, imaged at 6 months of age. And you can see here, this one looks a little bit bigger, a little bit more heterogeneous, and with color Doppler, just a lot of vascular flow. This is an infantile hemangioma, just another example for you to see. And sometimes these are really big. So severe infantile hemangiomas may lead to scarring or cosmetic abnormalities as they spontaneously regress, because as you can imagine, it distorts the adjacent tissue. And there's a medical therapy for severe infantile hemangiomas, and that's propranolol. This was sort of serendipitously discovered to have a positive effect on reducing the size of infantile hemangiomas, and it's pretty successful in more than 80% of cases. So here is an example of a very large infantile hemangioma in a 1-month-old. It was so big, it had some cystic changes, very vascular, very large. And so this baby went to see the cardiologist to get an approval to start propranolol. And after propranolol therapy, you can see that this infantile hemangioma is decreasing in size. Now, there is a differential diagnosis for an infant with new breast swelling. It might be a hemangioma, but it might be something else like this. This is a case of mastitis. We can see here this sort of irregular, ill-defined tissue deep to the nipple, and all of the adjacent soft tissue is very echogenic. This is what cellulitis looks like, and this is mastitis. So mastitis can occur in the pediatric patient, and the age occurrence is bimodal. So in babies can have this happen to them at less than 2 months of age. And it's likely that maternal or placental hormone-induced duct ectasia, so maybe the little neonatal breast ducts will dilate, and that facilitates bacterial entry, and the bacteria cause mastitis. It can also happen in teenagers, so children between preteens and teenagers between 8 to 17 years. And this is presumably secondary to breaks in the skin from infection or piercing and lactation. It's a clinical diagnosis, so you don't necessarily need ultrasound, but ultrasound can exclude abscess. So here's an example of mastitis and an abscess. We actually have an irregularly marginated hypoechoic heterogeneous lesion with posterior acoustic enhancement. So this tells us that it's fluid. This is all, and you can see it in real time. It's echogenic, gross pus within the breast tissue. So with neonatal mastitis, this will again occur during the first 2 months of life. It's almost always unilateral. Staphylococcus aureus is the most common infectious agent. There's swelling, redness, it's firm. It can be treated with oral antibiotics, but it can progress to abscess. And when there is an abscess in the neonatal breast, just expressing that pus using manual pressure is best, because again, we want to avoid any needle in or around the breast bud. We don't want to damage the breast bud. So whenever possible, avoid any needle puncture of a baby's breast tissue. All right, so here is a different case. This is an infant with new breast swelling, and you all may have seen a case like this and scratched your head and not know what to do with it. Well, the answer is nothing. So this is the example of a 7-day-old, first week of life, and palpable breast tissue, or palpable lumps under the nipple, I should say, more correctly. So this is an example of physiologic duct ectasia in the newborn. And so healthy infants and toddlers may have dilated mammary ducts. And this is fine. It's nothing to worry about. It can present as bloody nipple discharge in some kids or as a palpable mass. And again, it's this manifestation of the mini puberty of infancy, we think. And the treatment is just reassurance. This will go away. So do not put a needle in this. There's no need. Just reassure the family that this is okay and totally normal. All right, this is a different case now, that of a teenage boy with palpable subareolar lumps. So this is the case of a 15-year-old, and you can see these palpable subareolar areas of mixed echogenicity, ill-defined, and this is, of course, gynecomastia. So the development of breast tissue in the male is due to an imbalance of testosterone and estrogen, and it will lead to breast development. This can be unilateral, it could be asymmetrical and bilateral, and it can happen in both babies and in adolescents. And it typically resolves in adolescents and teenage boys within 2 years. And so the other thing to be aware of is that estrogen can be elevated by leptin, which is an enzyme produced in fat tissue. So boys who are obese have a higher propensity for gynecomastia. Certain medications can do it, most importantly, marijuana. So a lot of teenage boys who use marijuana may experience gynecomastia. Here is an example of very asymmetric gynecomastia, really pronounced on the right and hardly anything on the left. Maybe none on the left, so very asymmetrical. Here's a severe case. This is a lot of breast tissue, cyst formation in the breast. You can see this posterior acoustic enhancement behind these anechoic lesions. This is profound. And this is important to talk about when we see extreme gynecomastia or when gynecomastia arises in the prepubertal boy. This is very concerning. So we need to think about maybe the possibility of a hormone producing tumor like those listed here. We also want to think about liver disease. Does the child have liver disease? You could consider Klinefelter syndrome as a cause for gynecomastia. Here is a really interesting case, again, from my colleague, Dr. Restrepo. And at his center, they were treating an 11-year-old boy who kept presenting with small bowel intussusceptions. And in fact, he had to go to surgery to have some bowel resected because of this. Some bowel necrosis happened with bowel obstruction. Which is interesting. So after the surgery happened for his first bowel resection, 4 months later, he had abdominal pain and another small bowel intussusception, which is very strange. Now, at this time, it was noted that he had some breast tissue developing. And in retrospect, this was also evident on clinical exam. His adrenal glands were normal. And Dr. Restrepo noticed that on the pathology evaluation of the resected bowel, there were polyps. And so he put all of this together and realized that this child might have Peutz-Jeghers syndrome. And so he recommended a scrotal ultrasound, which shows this diffuse abnormality with multifocal echogenicities, and that was not microlithiasis, but was concerning for a diffuse neoplastic process like a large cell calcifying Sertoli tumor of the testis. And indeed, this boy was confirmed to have Peutz-Jeghers syndrome. So this is an example of tumor producing hormones that led to the gynecomastia. And then, of course, the polyps were the cause of the multiple small bowel intussusceptions and bowel obstruction. Okay, so just to emphasize, gynecomastia may be pathologic in a prepubescent boy or even an older teenager. It typically happens in around 15, sort of just as the boy is going through puberty. So think about the age of pubertal onset. Think about any exposure to medications or hormones, consumption of marijuana. Ask about a family history of gynecomastia, and then use ultrasound to evaluate the scrotum and the testes if there is, of course, testicular asymmetry or anything else in the history that might make you search for a hormone producing tumor. Okay. Let's move on to a different case. This is a 9-year-old girl with a palpable breast mass. And here's what we see. So we're seeing multiple tubular and round anechoic, well-demarcated structures with posterior acoustic enhancement. And so our differential here is multiple cysts, duct ectasia, juvenile papillomatosis, or maybe a lymphatic malformation of the chest wall extending into the breast. So this is the same case, a follow-up of the same patient at 1 year. No treatment was done. It just went away, And this is duct ectasia. So this is uncommon, but you will see it. It occurs in infancy, as we talked about earlier, and it can occur in early childhood. The retroareolar location is most common, so deep to the nipple is most common. And the clinical presentation might be a palpable tender area, or it could be bloody nipple discharge. And so we'll see these tubular anechoic structures deep to the nipple with posterior acoustic enhancement. And it may contain echogenic debris as well, and that debris might reflect blood products, or it could be infected fluid, or it could just be sediment. So here's a companion case, a different case of ductectasia in an 11-year-old girl. She presented with nipple pain and erythema. And after antibiotics, it was so large and painful, she was treated with antibiotics. And here you can see it decreasing in size. Now, in some cases with discomfort, sometimes it can be useful to aspirate these cysts just to relieve some pressure. But most often this will just go away on its own. Now here is, in the differential, I'd mentioned juvenile papillomatosis. I don't have any good examples of this other than an adult in her 20s. So this is taken from the literature from an old article, but juvenile papillomatosis is interesting. It's benign. It's a focal proliferative disorder. It manifests as a fibrotic mass with many little small cysts and dilated ducts. It's called kind of a Swiss cheese appearance on gross pathologic examination. And it's important because it could be an indicator or a marker of increased cancer risk. So if you see a child, a teenager with what looks like juvenile papillomatosis, you do want to refer that patient to a breast specialist for sure to talk about the potential for increased cancer risk. But this is so rare. Like I said, I've never seen one myself, except in an adult. Okay, so let's move on to a very common case that everyone needs to be comfortable with. This is a case of a palpable breast mass in a 14-year-old girl. And so, of course, she underwent breast ultrasound. And on the right side, at the 9 o'clock position, we see a solid mass. And so this is fairly well demarcated. It's oval in shape. It has internal heterogeneous echogenicity and posterior acoustic enhancement. This is a very common tissue type. It's a benign proliferation of fibroepithelial tissue. And the fibroadenoma is usually has these features listed here, and it is the most common solid breast mass in the pediatric population that we'll see, or specifically in the adolescent population that we'll see. So very, very common. They can be solitary, they can be multiple, and they usually present at age 15 to 17 with a painless, slowly growing mass like this. So there is a differential. We want to consider the possibility that we could be looking at a phyllodes tumor. So cystosarcoma phyllodes is a very rare tumor. It is the main differential consideration for fibroma. And the histology of a phyllodes tumor determines if it's benign, intermediate, or malignant. We cannot tell as radiologists. It's usually found in adults, and 85% of cases are benign. And the only thing we're going to rely on is size, which I'll emphasize in a moment. The other differential consideration is PASH, or pseudoangiomatous stromal hyperplasia. It's a benign and fairly common proliferation of mesenchymal cells in the breast tissue, but sometimes, uncommonly, it forms a mass like this. And here you could see a very enlarged breast that is full of this stromal hypoplasia. And so the key is that there's absence of circumscribed margins, absence of posterior acoustic enhancement, and that might help you diagnose this entity. For management, definitely follow up. And if there's growth of it, then surgical resection is required with wide margins. So what we're going to do when we think about an adenoma is categorize it in this bucket of fibroepithelial lesions. So the most common by far is conventional fibroadenoma. These other entities, such as a juvenile fibroadenoma, which is very cellular, or a giant fibroadenoma, or PASH, or a phyllodes tumor, these are less common, but could be developing in the breast. So what do? Well, we're going to use size. So if it's less than 5 centimeters, clinical follow-up is recommended. If it's greater than 5 centimeters, surgical consultation is appropriate to take that thing out. And then the pathologist can figure out what it is. So just keep in mind that size criteria of 5 centimeters. And that's how to manage these fibroepithelial lesions. Now let's finally wrap up by talking about the potential for actual malignancy in the breast. Again, it is exceedingly rare, but I want to show you a case of an invasive ductal carcinoma just to visually contrast with what we've been looking at. This is an invasive ductal carcinoma, and what we see is a peripheral solid mass in the breast. It's partially circumscribed, it's multilobulated, it's taller than it is wide, so it's got an anti-parallel configuration. It has heterogeneity internally, posterior acoustic shadowing, and it has little internal punctate calcifications. This is bad news. This is very ugly, and this is in fact an invasive ductal carcinoma. Does it occur in kids? Well, again, it is not just rare, but it is remarkably rare. So probably none of us will see this in our career. The risk of invasive carcinoma goes way up after 25 years of age. But in our pediatric population, we're just not going to see this. Now, what about certain risk factors for this? Definitely. So again, if a girl has a history of cancer, or a boy, particularly in children treated with chest wall radiation, those patients are at higher risk for developing a malignancy. And so the ACR recommends screening mammography after therapy completion, after a decade of therapy completion, but not before the age of 25. So again, this is not pertaining to our pediatric patients. These are just young adults. And then, of course, familial cancer syndromes such as BRCA elevate the risk. So that's invasive carcinoma. And then I just wanted to mention the possibility of other breast malignancies in children. Very rarely, again, a primary breast rhabdomyosarcoma might happen. As we all know, rhabdomyosarcoma is a common malignancy in children. And in the breast, this is very rare, just some scattered case reports. There's no specific sonographic finding because it's so rare, but let me show you a case that we saw. This is a solid mass. This is much more heterogeneous than is typical for a fibroadenoma. It had some internal vascularity. Much like a fibroadenoma, it does have posterior acoustic enhancement, but this just looks a bit unusual for a fibroadenoma. And so a breast surgeon saw this and felt like this was suspicious, did an ultrasound guided core biopsy, and indeed this was alveolar rhabdomyosarcoma. And so here's an axial image from an FDG PET scan showing this FDG avid malignancy here in the breast. So this is an example where, yeah, even though it's not 5 centimeters, the internal heterogeneity was unusual, and so they went ahead and decided to do a core biopsy, and that was appropriate. Here's another example from Dr. Restrepo. This is that of an 11-year-old girl who went from a bra size of A cup to D cup in 2 weeks. And we can see this extensive, ill-defined, heterogeneous solid tissue, and this was actually Burkitt lymphoma. So here you can see FDG PET maximum intensity projection images showing lymphoma everywhere, including in the breast tissue. So that's an unusual case. All right, so just to wrap this up, we'll talk about follow-up recommendations to summarize what we've been discussing. So in the first clinical situation, that of a baby or a young child, if there's a solid subareolar mass, this is probably just responding to maternal hormones, or it could be a hemangioma, and we do not need to biopsy that, just clinical follow-up. So what about a simple cystic mass in a child? If it's unilocular, well-circumscribed anechoic with posterior acoustic enhancement, usually no treatment at all for that, maybe just aspiration for comfort, but often nothing, just reassurance. The next clinical situation again is ductectasia. Again, this is likely to spontaneously resolve, nothing to do there. With a complex cystic mass, that could be an abscess or a hematoma. In the lactating patient, it could be a galactocele, and you could aspirate that and consider follow-up ultrasound for that, but just with a fine needle aspiration at most for that. Then when we get into our fibroepithelial lesions, again, most commonly a fibroadenoma, if they're less than 5 centimeters, just follow them. And the common thing to do is ultrasound follow-up in 6 months and then 1 year later. So document stability for 2 years at 6-month intervals and clinical follow-up. And then if it's growing or if it develops pain, then obtain a core needle biopsy and refer to a breast surgeon. Now, if it's straight away 5 centimeters or greater, then we want to consider these two entities and a surgical consultation at that time is appropriate. And then finally, any breast mass with an irregular shape, angular margin, shadowing, or if a patient has a personal history of cancer, then you can go ahead and pursue surgical consultation for anticipated surgical excision or tissue sampling. And then again, as I emphasized at the very beginning, any solid mass or complex cystic mass in the setting of prior or known cancer or prior radiation therapy, assume it's a metastatic lesion and sample that tissue just to be sure. Okay, so that is it. And now you guys are all pros. So you now know how to recognize normal breast buds and avoid harming them by sampling them with a needle. Don't do that. Subareolar findings are usually either normal or benign. A peripheral solid breast mass in teenagers are usually fibroadenomas, and clinical follow-up is appropriate. Remember that size of 5 centimeters to help you make a decision about what to do. And then finally, for any resulting histopathology that you're uncomfortable with, consult your local breast imaging colleague and discuss relevant follow-up imaging. So that is that, and here is some recommended reading if you want to learn more about this. And then if anyone has any questions, I'm happy to take them. Thank you very much.
Thank you so much, Teresa. We really enjoyed it. That was a really great lecture, very complete.
You're welcome.
And with a beautiful cases. I want to repeat the first thing that you said about to need a sample, to need a biopsy in a child is very rare. We have to be
Indeed.
in the proper scenario with a very fast growing tumor or with a very huge tumor. That's the most important thing that you told us to remember, because we can do a damage to the breast bud. It's not good. We have to be very careful about it, especially to know the normal anatomy to avoid this, and to remember that the last cases, the later cases that you show us are very rare, but we must keep in mind that must occur, they can occur, and we must be prepared for that. So that will be, well, that was really awesome. Well, we have two questions here in the chat. The first is with male adolescents with gynecomastia. We can use the classification, the Tanner classification for this gynecomastia.
So the good question. The Tanner classification is the clinical description of their pubertal stage. So with regard to gynecomastia, again, if they've started puberty, then some gynecomastia is not uncommon. But if they're prepubertal, so if they're Tanner stage 0, then you'd need to worry about that as being related to something, either medication or a tumor. And so the young boy that's Tanner stage 0 should not have gynecomastia. And then later, like Tanner stage 5, those boys and young men are post-pubertal and they should not have gynecomastia either. So it's really the boys that are in puberty and developing in their mid-adolescence those are the ones who might have gynecomastia and it's fine. And it typically resolves in 2 years. So hopefully that explains
Yes,
that.
we
Okay.
understand that. It's
Okay.
not just, well, it's not for classification, but it's more important for the context, for the setting.
Exactly. For the
Yes.
clinical context.
For
Yes.
the
Yeah.
because-
Right.
But the other question is, there is some special consideration. Oh, well, there is some classification in children like BI-RADS.
Yeah, no, we really don't need to apply the BI-RADS to children because again, they're almost always benign. So it's going to be BI-RADS 2 and 3, but we do not apply the BI-RADS classification to children in the United States. We don't need to. We sort of follow the same pattern of follow-up and expectations, but we don't put the BI-RADS classification in our reports for kids.
Yes, yes, I very agree with that. And this was made it for adults, so
Right,
it was used just for adults.
right.
So we have another question from Juan.
That's a good
And
question.
the question is that there are some lesions that resemble fibroadenoma in
In a young child, like
young
6
child.
years.
Yeah.
Yeah. Again, if fibroadenomas can happen in younger children. They are most commonly in teenagers, but if you see a solid mass that is small and it's well circumscribed and fairly uniform in its echogenicity and it has posterior acoustic enhancement, that's probably a fibroadenoma. So you could watch that even in the 6-year-old, again, as long as they don't have any prior history of cancer. So yes, fibroepithelial lesions can happen in youngsters, although less likely. So if anything strikes you as strange, you can consult a breast surgeon and talk about sampling that lesion. It's just in kids, virtually everything is benign again, and we really don't want to cause harm to that breast. So, so it's probably best to keep that child away from a breast surgeon so the surgeon doesn't do an
Yes.
unnecessary procedure.
Yes.
Yeah,
The follow-up, I think, is the best thing to do.
exactly. Just follow it up.
If the patient have, Juan said, the patient doesn't have any other history, any other, well, don't have mutation, familiar history, so it's okay
Right.
just to follow
Just
up.
follow it. Yeah, that's okay.
Well, we have another question. There are some differential diagnosis in a male patient with subariolar cyst.
In a male patient, really no. I mean, I shouldn't say no. Very rarely breast cancer happens in men. I have never seen one or heard of one in an adolescent boy, but theoretically it could. So if you see something with very ugly, concerning features, then you could consider any of the same breast lesions that we see in girls, including invasive breast cancer. But subareolar tissue in the boy, if it looks like normal glandular breast tissue, that's gynecomastia. Yeah.
That is very nice tip, I think.
Yeah.
Yes. Well, the last question that we have here is in a patient with BRCA mutation. The follow-up will be yearly with MRI, like in others, from which
Yeah. So thank you for the question. There are very nice specific recommendations for BRCA patients, but that screening doesn't happen until they're in their 20s. So to the best of my knowledge, we don't image adolescents annually by MRI screening with the BRCA mutation. However, the recommendations may have changed, and I apologize, I'm not perfectly confident about that. And so we as general pediatric radiologists should not be managing patients with BRCA mutations. That if you all have the luxury of dedicated breast imagers and breast surgeons, I would consult them for the management of that unusual situation. But my most recent reading of the literature for that does not recommend MRI screening until age 25 or later for the BRCA patients.
So because of the age, he's outside our field. So he's, again,
Yeah.
from adults radiologists.
Yeah.
Thank you so much, Teresa. I
Thank
really
you all.
enjoyed it. I really remember some cases of my experience. So it was really good
Good.
to have all these different cases, all the different scenarios. So I think that everyone here, all the people that can get this morning, and also the people that will review the record in our official channel,
Wonderful.
we're very happy to review this very important
Thank you,
lecture.
Carlos.
Thank you,
It's
Nadia.
really nice to be here. Thank you for everybody's kind comments in the chat, and stay well. Take care. Thank you.
Thank you so much. Had a great day, had a great year. And a todos los que estuvieron hoy día, muchas gracias por
Muchas
acompañarnos. Hasta
gracias.
luego.
Sí,
Bye.
adiós. Bye.
Muchas gracias a todos.